Think simply. Why? Simple thinking. He has thyroid nodule. He just have done the operation and there is hematoma. After operation, if there is hematoma, that means what is the problem? Maybe it has not totally repaired, like all the blood vessel is not secured. That's why there is hematoma. Because hematoma cannot come. Vitamin C deficiency can cause purpurulation, can cause curled hair, but it does not cause expanding hematoma. It is expanding. Most likely, it's just like he has done an operation and maybe he failed to secure all the blood bleeding vessels. That's why there is bleeding and hematoma. Okay, this patient developed an hematoma after core needle biopsy from an asymptomatic thyroid nodule. She has no personal or family history of easy bleeding or bruising, making vitamin deficiency and most hereditary bleeding disorder unlikely. Therefore, despite a core needle biopsy being a firmly low risk procedure, the most likely explanation for this hematoma is insufficient hemostasis following tissue injury from the biopsy. Okay. Uh, it is not look at the C and F, not vitamin C deficiency. It increased the risk of bleeding due to blood vessel fragility, and vitamin K deficiency can increase the risk of bleeding due to coagulation factor deficiency. This patient's lack of mucocutaneous bruising or bleeding makes this condition unlikely. In addition, a healthy individual who consume a relatively normal diet are at very low risk for vitamin deficiency. Yes. Ferritin is high means iron is locked up within the macrophage. Is it any chronic disorder? Mm. He has like rheumatoid arthritis, bilateral knee pain, joint stiffness, and he is taking just over the counter ibuprofen, not DMRDS. This patient has inflammatory arthritis, which is most consistent with early rheumatoid arthritis. Inflammatory arthritis, which is consistent with early RA. She has moderate anemia with low serum iron and TIBC consistent with anemia of chronic disease. Other characteristics lab findings of anemia of chronic disease include normocytic, normochromic, normochromic RBC, mildly decreased transferrin saturation, and normal to elevated ferritin. In contrast, iron deficiency anemia features elevated TIBC, low ferritin. Erythropoietin levels are variable, but anemia of chronic disease patients usually have low reticulocyte count relative to anemia severity, suggesting impaired red blood cell production. Anemia of chronic disease pathophysiology is thought to involve iron trapping within the macrophage, leading to reduced serum iron concentration and poor iron availability for hemoglobin synthesis. Decreased EPO production and poor marrow response to erythropoietin may play a role. Anemia of chronic disease is commonly associated with Anemia of chronic disease is commonly associated with chronic inflammatory disease, infection, cancer, autoimmune disorder, but can be also observed in heart disease, diabetes mellitus, acute inflammation. Treating the underlying inflammatory disorder will often improve the anemia. Common agents used in rheumatoid arthritis treatment include methotrexate, hydroxychloroquine, TNF inhibitors, infliximab, etanercept, erythropoietin or darbepoetin treatment may benefit anemia of chronic disease patient unresponsive to underlying inflammatory disorder treatment. Packed red cell packed blood cell transfusion are rarely required but can be considered after all other treatment interventions have failed. I got the diagnosis. Has anemia is present, thrombocytopenia is present, and there is antibiotic. Uh, Maha, and in the film there is helmet cell. There is triangular cell. Yes, Okay. Uh, this patient this patient has normocytic normochromic anemia. This patient has normocytic normochromic anemia, thrombocytopenia, and edema following a diarrheal illness. Finding that are suggestive of HAS. HAS most commonly occurs 5 to 10 days after an acute bloody diarrheal illness. Acute, acute bloody diarrheal illness caused by Shiga toxin producing strain of E. coli. The Shiga toxin induces endothelial damage in the renal glomeruli, leading to platelet activation, microthrombi formation, microangiopathic hemolytic anemia. The mechanical intravascular shearing of blood cell can result in jaundice or scleral icterus, as well as schistocyte fragmented RBC on peripheral blood smear as seen in this patient. Patients may have signs of thrombocytopenia, bruising, and acute kidney injury, edema, elevated BUN and creatinine. Treatment of HAS is supportive, include fluid and electrolyte management, blood transfusion, dialysis, treatment of prodromal antibiotics and antimortality agents, loperamide, as seen in this case, can increase the risk of developing HAS. Can increase the risk of developing HAS. Okay. Okay. Treatment of is supportive and electrolyte management, blood transfusion, and dialysis. Treatment of prodromal diarrhea with antibiotic and antimotiliary agents. Okay. Increase the risk of HAS. Okay. Neurological neurological symptoms. Is it volume overload? But a few minutes after the transfusion, he developed short. It is not volume overload because a few minutes after the transfusion start, uh, he receives multiple volume and is started on. Okay, sorry. He receives multiple volume of IV fluid and is started packed red cell a few minutes after. Okay, when he starts packed red cell, then there is shortness of breath. Okay, maybe. Ba- there will be bleeding, jaundice, severe back pain. Like not only just there may be, but we are wrong. Yes, yes, we missed that part. This patient's rapid deterioration immediately after blood transfusion is consistent with anaphylactic reaction. Anaphylaxis occurs seconds to minutes after initiation of the transfusion due to massive histamine release. Symptoms include respiratory distress, dyspnea, hypoxia, angioedema, and hypotension. Wheezing is often appreciated, although decreased breath sound can occur with severe bronchospasm, preventing air entry. Vomiting and urticaria may also be present. Without treatment, symptoms can rapidly progress to respiratory failure and shock. The first step in this management is to immediately stop the transfusion, administer intramuscular epinephrine, bronchodilator, and antihistamines are typically also administered. In some cases, hemodynamic and respiratory support, vessel pressure, and mechanical ventilation may be required. Patients with IgA deficiency are at higher risk of anaphylactic transfusion reaction because they may have anti-IgA antibody that react with donor blood IgA and contribute to histamine release. Although IgA deficiency can present with recurrent sinopulmonary infection, is often asymptomatic and may be diagnosed only after anaphylactic reaction. Future transfusion should include IgA deficient plasma and free washed red blood cell product. Yes, transfusion associated circulatory overload (TACO), characterized by pulmonary edema due to volume overload. Patients have respiratory distress, hypoxia, but hypotension would not be expected. Many patients are hypertensive. Yes, anaphylaxis onset is seconds to minutes. Anaphylaxis is recipient IgA antibody, recipient IgA antibody, shock, angioedema, urticaria, and respiratory distress. We haven't found this urticaria. We only found the respiratory distress. That's why we are distracted. But there was shock. BP was low. Transfusion related acute lung injury, minutes to hours, donor anti-leukocyte antibody, respiratory distress, non-cardiogenic pulmonary edema, and bilateral pulmonary infiltrate. Acute hemolysis, minutes to hours, ABO incompatibility, fever, flank pain, hemoglobinuria, and DIC. And finally, the bacterial sepsis, minutes to hours, bacterial contamination of the donor product, fever, chills, septic shock, and DIC. ABO incompatibility maybe. Even if cytokine release from even if there is fever, but there are lots of infection. 5 minutes after severe flank pain and there is bleeding like oozing. Okay. Okay, this patient likely has acute hemolytic transfusion reaction. Acute hemolytic transfusion reaction is rare, but life-threatening transfusion reaction typically caused by transfusion of mismatched blood, APO incompatibility, secondary to clerical error. Pathogenesis involves recipient antibodies reacting with the donor blood antigen, causing complement fixation and hemolysis as well as pro-inflammatory reaction. These patients develop fever, chills, hypotension within an hour after transfusion initiation. Non-specific flank pain is also characteristic. Hemolysis causing hemoglobinuria and may lead to acute renal failure due to acute tubular necrosis. DIC bleeding from the IVs and bleeding from the intravenous site as in this patient shock. Key findings include positive direct Coombs test, pink or dark brown plasma or and urine, and a repeat type and cross-match confirming a mismatch. Management includes immediate cessation of transfusion, aggressive IV fluid administration, and a supportive care. Delayed hemolytic transfusion reaction result from anamnestic antibody reaction to a red blood cell antigen to which the patient was previously sensitized. Pregnancy. In contrast to this site, patient typically develop extravascular hemolysis days to weeks after transfusion. And C. Transfusion transmitted bacterial infection (TTBI) due to bacterial contamination of blood product is characterized by fever, tachycardia, and hypotension around 30 minutes after transfusion completion. Flank pain is not associated with TTBI. In addition, transfusion transmitted bacterial infection most commonly occurs with platelet rather than RBC transfusion because platelets are stored at room temperature, which increases their susceptibility to bacterial growth. Yes, again, anaphylactic is within minutes, within seconds to minutes. There is recipient anti-Ig antibody against the donor blood Ig. There may be angioedema, hypotension, respiratory distress, and IgA variant recipient. IgA deficient recipient. Acute hemolytic within an hour. ABO incompatibility, often clerical error, fever, flank pain, hemoglobin, DIC positive Coombs. Febrile non-hemolytic, it is also within 1 to 6 hours. Non-hemolytic is cytokine accumulation uh, during blood storage, fever and chills. Arterial within 2 to 3 hours. Recipient IgE against the blood products. Arterial. TRALI is donor anti-leukocyte antibody within days to weeks. Often asymptomatic lab evidence of hemolytic anemia, positive Coombs test, positive antibodies, new antibody screen, and graft versus host disease within weeks. Donor T lymphocyte rash, fever, GI symptoms, and pancytopenia. Okay. He does not have von Willebrand because PTT is normal and no factor problem. Factor rate again PTT is normal. Platelet hemoglobin electrophoresis for sickle cell or thalassemia, isn't it? Not like this is sickle cell or thalassemia. Vitamin C. What are the other, like there is scattered petechiae? Maybe. But platelet is very low. Uh, uh, as far I remember, is it SLE? Okay. Is it platelet? Okay. ANA screen for SLE. We are completely reverse tracked. Okay, it's ITP. Okay, first box. Common acquired form of thrombocytopenia. Commonly acquired form of thrombocytopenia. There may be autoantibody formation. Often recent viral infection or comorbidity HIV, HCV, and CLL. Frequently asymptomatic um, mucocutaneous bleeding. There may be menorrhagia, ecchymosis, petechiae, purpura. Severe hemorrhage is rare. Diagnosis of exclusion. And diagnosis normal coagulation tests, platelet morphology. There may be peripheral smear. HIV, HCV testing commonly includes ITP. Observation if no bleeding and platelet is more than 30,000, then observation if no bleeding and platelet more than 30,000. Corticosteroid if platelet is less than 30,000 and IVIG and platelet transfusion if hemorrhage. Okay, ITP is an acquired disorder marked by formation of the autoantibody to platelet surface glycoproteins, which increases platelet clearance in the spleen, inhibits megakaryocytes. In ITP, platelet counts fall to decrease 1 lakh, leading to profound skin or mucosal bleeding, menstrual or nasal ecchymosis, petechiae. ITP is a diagnosis of exclusion. Therefore, other cause of thrombocytopenia, drug-induced thrombocytopenia, liver disease, hypersplenism, microangiopathic disorder, and bone marrow abnormalities must be ruled out. In ITP, leukocyte count, erythrocyte count, and coagulation disorder are normal. Peripheral blood smear usually show normal platelet morphology, but both normal sized and large platelet may be seen due to increased platelet turnover. ITP is categorized as either primary or secondary. HIV and hepatitis C is the most common secondary cause, so testing for these two conditions is generally performed. Additional testing is warranted when specific signs or symptoms of another disorder is present. These patients' myalgia and arthalgia raise concern for autoimmune disease, SLE, and therefore anti-nuclear antibody is advisable. Yes. Ascorbic acid deficiency causes impaired coagulation synthesis, can lead to ecchymosis and purpura. However, most cases occur in severely malnourished individuals or those who use alcohol or illicit drugs. And platelet aggregation testing evaluates for rare disorder like platelet function and is generally indicated in those who have normal platelet function and prolonged bleeding times. These patients' thrombocytopenia makes ITP far more likely. Platelet aggregation testing would not be indicated. Whiskered Aldrich, Mr. Text, mutation in the WAS gene, thrombocytopenia, eczema. Yes, Mr. Text, mutation in the WAS gene, impaired cytoskeleton changes. Okay. Mr. Text, yes. When I say something like weird, think about mnemonic because Mr. MRTEXT. XT. Okay. Uh, Mr. Text mutation in the WAS gene, and there is microthrombocytopenia. Actually, T for thrombocytopenia. Okay, first I am telling in my way, then you write. Mutation in the WAS gene, recurrent infection, thrombocytopenia, eczema, X-linked, and there is a tumor. You will found that in the first aid there is a chance of having tumor. Okay. Yes, R for recurrent infection, and T for thrombocytopenia, E for eczema, X for X-linked recessive defect, and another T is tumor, or another T you can remember via transplant, like stem cell transplant should be down, transplant. Yes. Infections. Okay, we have already read the box, like all the thing came in to our mnemonic. Okay, this patient's eczema, microthrombocytopenia, and recurrent infection consistent with Wiskott-Aldrich syndrome. WAS is caused by X-linked recessive defect in the WAS gene. This gene is primarily expressed in hematopoietic cell and regulates cytoskeleton remodeling in response to cell signaling. In WAS, the acting cytoskeleton in which WBC is abnormal, resulting in immune-mediated dysfunction due to impaired cellular migration and immune synapse formation. Patients are at increased risk for recurrent bacterial, viral, or fungal infection. Similarly, the cytoskeleton of the platelet is dysfunctional. Virtually all patients have significantly decreased platelet counts and size at the time of the diagnosis. The resulting clinical finding can range from petechiae or purpura to severe bleeding such as intracranial hemorrhage, hematemesis, hematochezia. In addition to autoimmune disorder, eczema occur in most patients with WAS. The treatment of WAS is hematopoietic stem cell transplantation. Okay, maybe there is cytoskeletal changes like leukocyte, platelet. Uh, these two cannot be formed, especially the thrombocytopenia. Sorry, especially the leukocyte one. Sorry, platelet one. Yes, ataxia telangiectasia. Ataxia telangiectasia is a T cell deficiency associated with DNA repair. In addition to immune dysfunction, patients with ataxia telangiectasia experience progressive cerebral degeneration are at high risk for cancer. Low. And then he is on antibiotic. Then this happened. TM, sorry, he is on TMPSMX. Is this alcoholic? Alcohol can cause macrocytosis if somebody is on alcoholic. And no, no, I don't want to say this. I am very concerned on medication adverse effect. TMPSMX can cause agranulocytosis, like other thyroid drugs, hyperthyroid drugs, like antipsychotic drugs, clozapines. Okay, drug-induced neutropenia, methimazole, propylthiouracil, trimethoprim, sulfamethoxazole, clozapine, and sulfasalazine. Immune-mediated drug or metabolite binds to the neutrophil and triggers a cell-mediated or humoral response. Bone marrow toxicity and drug or metabolite directly or indirectly damages the granulocyte precursor, usually within 3 months of drug exposure. Oropharyngeal ulceration with or without fever and other cell lines unaffected. Discontinue inciting medication, antibiotics in the setting of treatable infection, and consider granulocyte colony stimulating factor. Patients with alcohol use disorder cirrhosis may develop leukopenia due to a variety of conditions. Two of the most common etiologies are alcohol-induced bone marrow toxicity and vitamin B12 deficiency. However, these causes tend to be slow in onset and to cause mild neutropenia. Absolute neutrophil count more than 1000 Given the recent initiation of trimethoprim sulfamethoxazole for Given the new initiation of trimethoprim sulfamethoxazole for spontaneous bacterial peritonitis prophylaxis, the most likely etiology of this patient's severe neutropenia, absolute neutrophil count less than 500, is called drug-induced neutropenia. Drug-induced neutropenia is generally triggered by direct bone marrow toxicity, is a dose-dependent manner, chemotherapy, or an idiosyncratic reaction due to attachment of drug or drug metabolite to the neutrophil surface, which triggers a cell-mediated or humoral immune response. Most cases, patient with oropharyngeal ulceration or fever. The other cell lines, erythrocyte platelets, are generally normal unless a different condition is altering rates of production or altering rates of production or destruction. In this case, this patient likely has mild macrocytic anemia due to alcohol toxicity or vitamin B12 deficiency or folate deficiency, mild thrombocytopenia due to hypersplenism. Okay. Yes, I think that it is the sorry, it is head neck cancer. Head neck cancer. Yes, it is present. D is laryngopharyngoscopy. Okay. Okay, can you hear me now? Okay. Okay, it's laryngopharyngoscopy. Malignancy is extremely likely. Malignancy is extremely likely in a patient with persistent more than 2 weeks, palpable, more than 1.5 centimeter firm neck mass who has smoking history and no history of preceding infection. By far the most common cause of malignancy to manifest in the upper in an upper cervical lymph node is mucosal head and neck squamous cell carcinoma. Head and neck squamous cell carcinoma is common in patients with significant history of alcohol and tobacco use, as in this patient. The first apparent manifestation is often palpable cervical lymph node, which represents regional nodal metastasis. Indication of primary source of squamous cell carcinoma is a paramount uh, importance because it directs all treatment decisions Although SCC can originate from many sites, skin, uterine cervix, and upper esophagus, the vast majority of the cervical nodal SCC arises from the mucosal surfaces of the head and neck, nasopharynx, oral cavity, oropharynx, larynx. Through examination of these structure must include endoscopic visualization using laryngopharyngoscopy. Next. Maybe because leukocyte is very high and myelocyte, metamyelocyte is higher, so looks like CML. CLL lymphocyte would be very higher in CML. Yes, ALL for little people, ALL for babies, AML or rods. AML can come with the DIC. Okay, if we compare the leukemoid reaction and CML, in leukemoid reaction, leukocyte count is markedly elevated more than 50,000, and in CML it is markedly elevated more than 1 lakh leukocyte count. Cause severe infection. CML is BCR-ABL fusion gene, BCR-ABL1 fusion gene. In leukemoid reaction, as it is infection, lab leukocyte alkaline phosphatase is higher, but in CML, as it is cancer, so lab is low. Neutrophil precursor more mature metamyelocyte are more in leukemoid reaction than the myelocyte, and in CML, metamyelocyte is low, myelocyte is more. Absolute basophilia is for CML. CML can come with absolute basophilia. Okay, okay. CML is a myeloproliferative neoplasm caused by BCR-ABL fusion gene. It is marked by dramatic leukocytosis, absolute basophilia, a preponderance of early immature neutrophil precursor, promyelocyte, myelocyte. The lab score can help to differentiate CML from the leukemia reaction. In CML, the neutrophils are cytochemically and functionally abnormal, so the lab score is low. CML is often on routine blood work in asymptomatic patients, but may present with fatigue, weight loss, night sweat, or abdominal fullness from splenomegaly. Thrombocytosis and anemia are common. Okay, he has aplastic crisis. Just think simply. He has aplastic crisis. There are two crises in sickle cell patient: aplastic crisis and you. If you read the whole stem, you cannot identify if you don't know the reticulocyte count. Has aplastic aplastic crisis has low reticulocyte count. Hemoglobin is low in sickle cell patient. Normally, hemoglobin is low, isn't it? There are two crises like splenic sequestration crisis and aplastic crisis, where reticulocyte count is high, where reticulocyte count is low. I okay, yes, but the leukocyte count is normal. Even platelet is normal. So aplastic crisis. Think about aplastic crisis. That means absence of reticulocyte count. And splenic sequestration crisis, there is severe reticulocyte count. That's it. Okay, in aplastic crisis, there is absent reticulocyte count, so arrest of erythropoiesis, there is transient arrest of erythropoiesis and secondary infection of ROS B19. And splenic sequestration crisis, severe reticulocyte counts, splenic vaso-occlusion, rapidly enlarging spleen occur in children prior to splenectomy. Sickle cell disease is characterized by chronic anemia with a compensatory reticulocytosis. Patients with sickle cell disease have increased red blood cell destruction, at baseline, are at risk for actively worsening severe anemia, an acute drop in hemoglobin, accompanied by low reticulocyte count without splenomegaly, is consistent with aplastic crisis, which is characterized by sudden halt in the RBC production erythropoiesis. Anemia is typically severe, less than 6, and patients may have pallor, fatigue, and functional systolic murmur due to hyperdynamic blood flow. White blood cell and platelet counts are typically normal. The most common causes of aplastic crisis is parvovirus B19, which infects and destroys the erythrocyte precursor. Aplastic crisis is generally present before age 15, as parvovirus outbreaks are most common in school-aged children, although erythema infectiosum fever rash is the classic presentation in children. Parvovirus B19 infection can result in aplastic crisis with no preceding viral symptoms. Blood transfusion are the mainstay of treatment. Okay. Yes, yes. Okay.